Well, hello, everybody. Good afternoon. My name is Garrett Schmidt, and I'm the managing editor and CEO for BBC Exhibit Hall. And I'd like to welcome you to today's live webinar hosted by Symbion Coding. And I've been very excited about this one. It's gotten a lot of attention, and there's a big audience today. And this one is called CMS Has Announced Increased Audits, Preparing Your Practice for the Inevitable. So I got a little bit of a sneak peek when we did a practice run, and I think you'll be really happy with what we're going to discuss today. So a few items of note before we get started. Everyone has joined today in listen only mode. So this is going to be a traditional webinar format. You don't need to worry about turning off your mic or your camera. That's been done for you. But we do want to hear from you. We're going to have a time for some Q&A towards the end of our presentation today. So if you have a question for either of our speakers at any point, then you can use your control module. There's a little attendee module. There's a place for questions specifically. So go ahead and drop those in there. We do have a big crowd today, so if we don't get to yours for some reason, don't worry. Someone will reach out via email and make sure that we get your question answered. So even if we're wrapping up at the last minute, go ahead and drop your question in. Finally, today's session is being recorded. So what's going to happen is when we conclude, maybe about an hour or so after the presentation, you will receive an email, and that email will have a link to the recording as well as to the slides from today's presentation, and that way you can watch it again at your leisure and or share it with colleagues and friends, and we hope that you do. So without further ado, because we've got a lot to cover today, I'm going to turn it over to our speakers. With us, we have Mr. Gene Delva. He is the founder and CEO of Symbion Coding, and also Dr. Jose Guton, and he is a physician leader and value-based care expert. So welcome, gentlemen.
Hello, everyone, and welcome. I'm Gene Dalva, founder and CEO of Symbion Coding. Dr. Guton and I are so happy that you have decided to attend today's session titled CMS has announced increased audits, preparing your practice for the inevitable. The goal of this presentation is to share some practical items that healthcare organizations of all sizes can take as soon as possible to start preparing for what's to come. Again, thank you for being here. Without further ado, I will turn it over to Dr. Guton.
Well, thank you, Gene, and I too want to thank everybody for their time this afternoon. I'm Joe Guton. I'm a family physician. I've spent the better part of my career in the Medicare Advantage sector. I'm the founder and CEO of Covenant Consulting, my advisory firm, which works with primary care physicians and physician groups to help them navigate and to thrive in value-based care. I'm very pleased to meet my good partner, Gene and Garrett. I'm a part of the advisory board at VBC Exhibit Halls, and I encourage you to chat with Garrett after the session to explore how your organization can benefit from the Hall's many resources. So without further ado, I think Gene is going to drive the presentation. Let's go to the next slide. We're going to start by asking the audience some questions, and along the presentation, you'll hear us ask several questions. You know, what's driving this? What does this mean? What are the implications? But I think the most important question that we can frame this afternoon is, are you ready? Are you ready for audits? Because they are coming. So we want to first get a sense of who is the audience this afternoon. And the first question is, what best describes your organization or affiliation? So pick one of these. This will help us out, and I think it'll share valuable information to you as a participant on today's seminar.
All right, so you will see this up on your screen, and I apologize if the sound is a little fuzzy, and we're aware of that, and had some technical issues this morning, so Dr. Guton is having to call in rather than be on the thing, so please bear with us there. But what you're seeing on your screen now this is anonymous, by the way, so feel free to answer these questions that we're asking today, and we're going to show the results so you can see where you stack among your colleagues. So I think there's still some results coming in, so we'll give it maybe another 10 seconds or so. What it best describes your organization or affiliation. Now, we realize that you can be multiple of these things. And so whichever best applies, you an insurance company payer, are you a provider? And that could be either for profit or not for profit. We were thinking about even differentiating it that way, but we ran out of question options, in all honesty, that we could ask or go to webinar. But I think most of the results are in here. So we're going to go ahead and close it down in about 5, 4, 3, 2, and 1, and I'm going to go ahead and show the results. Okay, Dr. Gatton and Jean, are you able to see these on your screen?
I only see the first 3.
Okay, you should be able to scroll down a little bit on that, but I'll go
Yes.
ahead and read out. Yeah, there we go. So it's and by the way, if you're calling in or if in the recording you can't see the results, I'll go ahead and read them out real quick. We've got 14% are affiliated with payers. We've got 26% providers, 13% in the vendor consultant services sector, and we've got 34% of you are hospital health system CINs, and then 18% are with ACOs. So good mix here.
Indeed, that's a great mix, and I'm glad to see that it's a broad-based audience listening to this presentation. We also think it's important to get some understanding about your specific role at this organization or this company. So I think the next question has to do with which category, which title best describes your current role.
Yeah, and so again, this is anonymous, so whatever best applies. Obviously, if it's something other than that, then maybe actually what could be fun is to drop that in the chat and just see what if there's something that's it's not any of these, which is certainly possible with this size crowd today. But are you a coder, biller? Are you nurse or provider, nurse or physician? Management, C-suite level? Are you compliance auditor? And again, this is the one that's going to best describe where you're at. So we've got, I would say most of the results are coming in, and we'll give it another 10 seconds or so for folks to answer, and we'll turn it over. We know we got a lot to cover today. So, all right, I'm going to shut it down in 5, 4, 3, 2, and 1. All right. It looks like we've got 25% of you are coder, biller, RCM. We've got 11% of you are providers, nurse, or physicians. Thank you so much for your service and what you do in the industry. You know, that's hard work. 32% of you are management, C-suite level. Welcome. And then we got 31% of you are in compliance or an auditor. So also a good mix today.
Indeed, it's a good mix. One of the things that I want to communicate is that to prepare an organization for a successful audit, it takes a village. So I'm glad that all of these folks from the various departments or functional areas are on the call today. It takes a group effort. It's not just the providers or clinicians in the front lines, and it's not just our coders. It takes, top, bottom, and bottom up approach to preparing the organization for an audit. Thank you, Garrett. Appreciate it. And I think Garrett's going to put this in the chat, but I wanted to just present these statements, these declarations, and ask you, think about your organization and and decide, is this statement something that I can confidently agree with, or strongly agree with, or not, or somewhere in the middle. And the first one is, I'm confident that my organization would pass an audit successfully today.
With these, sorry to interrupt, Dr. Guton. With these, what you want to do is go ahead and rate maybe 1 to 5 your readiness for these in the chat. Go ahead and just drop that answer in there. So for the first question, 1 through 5. Again, 1 being what do we want to say, Joe? The best or the worst?
No, the worst.
1 is the worst. 5 is you are fully ready. So 1 through 5 for all of these. So go ahead and continue.
Yeah, I'll read them, and that way it gives everyone time to sort of consider their level of preparedness. The second one is, my company or organization is adequately prepared for an audit today. My company or organization takes a holistic and comprehensive approach to audits and compliance. And then finally, we have a clear picture of our top diagnostic codes and patient mix.
What you can do is make 1 4-digit number, if that's easiest, to represent each one. So like someone put in 2222, so there are 2s across the board. And if you can't find the chat, by the way, it should be a little area up to the top right, which is, and it's you can also put it into the questions if that's easier. There's a little area for the questions. And we'll give folks just another couple minutes. And this may be a little bit, Dr. Guton and Jean, this may be a little bit more difficult to see from your perspective, but we got a lot of kind of a mixed bag, a lot of 3s coming in across the board, a couple 5s, so that's great, all the way across. Some 2s in there, so it looks like, again, a pretty good mix here, so that there should be a little something here for everybody.
That's a good way to put it. Thanks. Well, here is that famous announcement, and I embedded the link so that you can go and read it for yourselves. I think that it's important reading, and if you felt that this session was important enough to attend, then I think the reading is important enough as well. The final rule announces certain policies to improve the program integrity and payment accuracy in the Medicare Advantage program. Specifically, the final rule codifies regulation that is part of the RADV audit methodology. CMS will extrapolate RADV audit findings beginning with payment year 2018. Will not extrapolate the RADV audit findings for years 2011 through 2017. CMS is also finalizing a policy whereby CMS will not apply the adjustment factor known as the fee-for-service adjuster in those RADV audits. Finally, they're codifying in the regulation the requirement that MA organizations remit improper payments identified during the audits in a manner that is specified by CMS, although they don't specify what those specifications are. Next page. Not sure why this slide is in there. Actually, I do know, and that's because audits are coming more frequently. This was a white paper that I downloaded from the folks at Healthicity, and you can also go to that link in orange, and I would recommend you look through that. It outlines 13 different types of audits in the healthcare arena. Now, why? Well, when changes come through CMS, like this announcement, it's a signal that they're looking at other sectors of the industry. So this is not just for those folks in Medicare Advantage. If you have Medicaid patients, if you see original Medicare patients, if you see commercial patients, the payers, particularly the government payers, are preparing to do more audits and look to ensure that the payments are supported by the clinical documentation. Next slide. And by the way, if you can't open that link, I'm just going to itemize very quickly those 13 different audits. Commercial payer audits,
It
federal
will be in the
government
slides, by
audits.
the way. It's like when you download
Oh,
the slides, that hot link will be in there. So just for
okay.
your knowledge.
Excellent, excellent. So again, it's very broad. It's quality improvements. It's audits that may be proactive or reactive, audits that are external, internal, prospective, retrospective, hybrid audits. So it's important to just get familiar with the type of audits that you may be facing in the near future. I selected these 4 key excerpts from the announcement, so let's just look at those real quickly. One is a quote from the new CMS administrator, Dr. Oz, and that is, "We are committed to crushing fraud, waste, and abuse across all federal healthcare programs." Again, an emphasis on all healthcare, federal healthcare programs. The second one is CMS is, can you increase the font? Let me see if I can do it here. I'm reading. There we go. Is several years behind in completing the audits. The last significant recovery was in payment year 2007. Number 3 is the Trump administration has introduced a plan to complete all remaining audits for 2018 through 2024 by early 2026. And the key elements of the plan include enhanced technology, workforce expansion, a significant expansion, as you can see there, from about 40 to 2,000 coding professionals, and an increase in the audit volume, both in terms of the number of MA plans audited, but also the number of records, from about 35 to making 200 the standard sample that they will audit for each plan and for the payment year. This helps to ensure that CMS are more reliable and can appropriately be extrapolated as allowed under the RADV final rule. Now, I want to just do a little level setting here and clarify how extrapolation works. So CMS selects a sample of enrollees from an MA plan and reviews their medical records to validate that the diagnosis that were used to calculate their risk scores match or are aligned. If the diagnoses are found to be unsupported in the medical record, then CMS may recoup overpayments. Extrapolation takes the error rate found in that sample and applies it to the entire population of enrollees covered by that plan for the audited year. And so the impact of extrapolation can be significant, even in the case where there's a small error rate. It can translate into a very large overpayment demand in a plan, for example, that has 50 or 100,000 members or greater. So it can be financially significant. Next slide. So what's behind this announcement? I think clearly there are 3 factors, whether they were mentioned or not. One is the economics and the finance. Medicare spends a significant amount of dollars in the Medicare Advantage program, and they want to make sure that they are correct in how they pay for the program. Accountability and stewardship, I think, that was a common theme that we heard at the National RISE conference back in February, and they want to apply that accountability across all federal departments to make sure that spending is appropriate. And then just the backlog, embarrassing as it is, there's a significant backlog of audits that they need to get through. And so this is part of why there's this expansion in staffing and more frequent auditing. At the end of the announcement, there's a reference here to the final RADV rule. And if you click underneath here, it is also an embedded link that you can read in greater detail about that final RADV rule. Let's peel that back now. Next slide. So as I said, the CMS is increasing the sample size to 200 enrollees, and they are looking at doing audits on far more MA plans per payment year than in the past. It is part of the, excuse me, it is also it's repeating what was in the announcement in terms of eliminating the fee-for-service adjustment factor. It emphasizes that the MAOs will again remit improper payments in a specified manner by CMS, although no details are given yet. This gives CMS more time by eliminating years 2011 through 2017. It gives them time to process RADV audit appeals, and it allows CMS to conduct future audits as soon as practical after the payment year has ended. Next slide. So what does all this mean? For sure, it means greater scrutiny. There still remains lack of clarity with the new administration, particularly when you consider the speed of changes across all government departments, and really the fact that it's been only 5 months in. Gene and I attended that RISE conference in San Antonio, and a common theme we heard was everything is on the table, and I quote. So you can read what you want from that, but I think that the message is you need to prepare your organizations going forward, and there has to be a significant value and level of importance placed on compliance. Next slide. What are the implications? Well, in broad terms, it comes down to these three buckets of risk. One is the higher risk of audit exposure, the potential financial risk, and legal and reputational risk as well. Next slide. Here are some recommended actions. And I put them in these three broad categories. One is strengthening your internal compliance programs, and thankfully we have Gene as an expert on the session today. He will cover more practical recommendations. for your organizations in terms of getting prepared. Audit high-risk areas must be treated proactively, and enhancing provider education. I want to just pause for a second and share a joke. Now, I want to set a disclaimer here. I mean no disrespect. I completely made this up just to exaggerate a point that I want to make. So, if you're ready, I'm ready. So a doctor, a hospital administrator, and a coder walk into a bar together. Now, Garrett, don't worry, it's not that joke. Gene, it's not the one about you. The bartender asked the doctor, well, what can I get for you? The doctor says, I want a vodka martini. Okay. She asked the administrator, who says, I want a gin and tonic. All right. And she asked the coder, what about you? What can I get you to drink? The coder says, I'm just fine with a club soda and lime. And so she's like, okay. And she's watching these three enjoy their drinks. And she goes over to the doctor and says, so what do you do for a living? And the doctor says, well, I'm a surgeon. She says, oh, wow, how interesting, how interesting. And then she proceeds to ask the administrator, who says, I make sure that guys like that one stay in their lanes. I want to make sure that that they do the right thing. And so she listens to this, and she's a little puzzled. She looks over to the coder, and before she could even ask, the coder says, and what do I do for a living? I keep those two from going to jail. Now, thankfully, I'm not a comedian, but my point is that coders are incredibly valuable to your organizations, and I just ask that you treat them as such. I've been working with coders for many years. I've been with coders in breakout sessions and AHIMA meetings, and I have collaborated with them in multiple settings. They are incredibly dedicated professionals. They are passionate about what they do, and we need them more now than ever before. And even if you deploy computer-assisted coding or autonomous coding, you need the talent and the experience of certified professional coders, and that was my point. All right, next slide. Gene, help me with the next slide. Oh. There we go. Just a summary of my recommendations. And basically it's this: as an organization, come together and just look at yourself in the mirror. It's important that you get to know who your patients are. It's important that you understand your contracts. It's important that you know your numbers, your population, your codes, know your numbers, know your risks or your gaps. If you have had prior audits, if you conduct internal audits, if you have experts like Symbion who do audits of your providers, it's important that every audit report is reviewed, is analyzed, and that there's a corrective action plan that corresponds to every audit in the company. And then just the point I made earlier about making sure this is a team approach. All the stakeholders should be engaged and unified on this issue of proper coding. Again, both top-down and bottom-up leadership approach is needed as you evaluate your organization, and it should be honest and it should be transparent. Now I'm going to turn it over to my good friend and partner, Gene Delva, the founder and CEO of Symbion Coding.
Thank you very much, Dr. Gutton, for the wonderful information you just shared with us. Really appreciate it. So for my portion, I will be talking about a few things that a coding department or risk adjustment department can do now to start preparing for what's to come. We don't know exactly how CMS is going to do their audits, but we can learn a lot from the past. And in the past, CMS has done two types of audits at least. One of them is called high risk diagnosis and RADV. What is a high risk diagnosis? So a high risk diagnosis is defined as diagnosis that CMS has identified as being frequently unsupported by medical record documentation. As you can see, we have at least 10 here. Acute heart attack, I'm not going to read everything. Breast cancer, major depressive disorder, about 10. We're going to talk briefly about each one. For acute heart attack and acute stroke, those are normally inpatient type of diagnosis. That's where you'll find this type of diagnosis. Now, if a physician diagnose a patient with acute heart attack or acute stroke, what CMS is going to do, they're going to try to see if there's a claim in the inpatient side. Now, when they don't see any claim on the inpatient side, they see, you know what, something is probably wrong. Let's review that medical record. That's the logic behind it. Now, for breast, colon, or lung cancer, it's almost the same concept. If someone is diagnosed with any of this type of cancer, and CMS did not receive any surgery, radiation, or chemotherapy drug treatment claim, they don't see any drug treatment administered within 6 months before or after the diagnosis. They say, you know what, something might be wrong here. Let me review the medical record. Now, for prostate cancer, is almost the same concept. It's exactly the same concept. The only difference is that there's an age limit. This is 74 years of age or younger. And the logic is very simple because most male patients, if they have prostate cancer, they are extremely old, 85 or 90 years old. They may not want to go through chemo or surgery for prostate cancer. That's why they have that age limit in there. Embolism, vascular claudication, major depressive disorder. If someone is diagnosed with any of these diagnoses, they see if there's a medication dispensed on behalf of the patient. For embolism, they'll check to see if there's any anticoagulant medication. For vascular claudication, they will check to see if patient is on vascular claudication medication, not neurogenic claudication medication. And for major depressive disorder, they will see if the patient is on any type of antidepressant. Please note that the fact that a patient is not on any medication, that doesn't mean that that will be unsupported, that diagnosis will be unsupported, because there might be some good reason for a patient not to be on certain type of medications. However, if the note can actually show exactly why patient is not on that medication, CMS will validate the diagnosis, but the progress note or the documentation has to be clear enough. Now, when we look at the results for high-risk diagnosis, we can learn a lot. And I have a case studies about three of them. We have Cigna Health Spring of Tennessee, Geisinger, and UCare. Now, for Cigna, the error rate was 69.89%. And OIG estimated that Cigna received at least $5.9 million in overpayment for 2016 and 2017. Geisinger error rate is 82.96%, very high. And OIG estimated that Geisinger received at least $6.5 million of net overpayment for 2016 and 2017. And UCare error rate was 86.39%. And OIG estimated that UCare received at least $4.7 million in net overpayment for 2018 and 2019. As you can see, very big, huge error rate when they do this type of high-risk diagnosis audit. Now, is that the only type of audit that CMS has performed in the past? No, they do any type of HCC or HCC type of audit. And here's a case study about three of them. Emblem Health, error rate was 29.62%. Now, notice the amount. OIG estimated that Emblem Health received at least $130 million in net overpayment for 2015. Care Plus, 26.93% error rate, and OIG estimated that Care Plus received at least $117.3 million of net overpayment for 2015. Now, one question you may want to ask yourself is why for high risk diagnosis we have a bigger error rate, but the amount seems to be a lot smaller. Where here the error rate seems to be a lot smaller and the estimated money of overpayment seems to be a lot larger. Why is that? And the reason is very simple. When they do a high risk diagnosis, we are talking about a very small subset of the population for that health plan. We are talking not just about patients with breast cancer, but breast cancer, they don't see any claim for surgery, for radiation therapy treatment. It's very small. So when they do a high risk diagnosis audit, that's not gonna change the average risk score for that health plan. So that's why the amount is a lot smaller. However, when they do any ATC audit, all the universe of ATC audit, now even though the area is smaller, but they have the whole universe. And that's going to significantly change the average risk score for them. And the best way we can illustrate that is like having 29% of a watermelon versus 85% of a grape. Of course, you're going to get a lot more if you have 29% of a watermelon. Now, what are some things some organization or all healthcare organizations should start doing right now? Here are a few steps. We're not going to read all of them, but we're going to talk about each one of them. The first one is solidify the foundation. To do that, you need to have executive buy-in. And to have executive buy-in, you have to be able to speak the language of an executive. Most of the time, executives are typically focused on the big picture, strategic goals, profitability, risk mitigation, and return on investment. For example, you can work with your finance department to show that 5% error rate could result in X amount of $1 million in penalties. So that way you can get your executives' attention. You can also show that by investing in enhanced RADV readiness now can actually save some money. The other thing is that it is very crucial that you know the executive individual style because some executives prefer data heavy presentations. Others prefer a concise executive summary. And some are more interested in the human impact. Tailor your communication style to each key decision maker so that way you can grab their attention. Finally, you need to be ready for tough questions because if you work as a coding manager or vice president of risk adjustment, that's your only focus. Now, executive has a lot of things to worry about. That's why you have to be ready to answer questions that they may have. The other thing, it is very important to start looking at your policies and procedures now. You need to know if your policies and procedures have anything related to a RADV audit. If there's a medical record request, who's going to be in charge? What's the process going to look like? You need to have that document in your policies and procedures as well. The third thing that you can do is to know your data. And Dr. Goton already talked about that. You need to do regular internal audits. Focus on high risk areas like such as drug dependency, cancers, and also you need to know who's your weakest coder when it comes to coding accuracy. And some organizations now have the providers doing the coding. You need to know who's the weakest providers when it comes to coding accuracy. Start helping these people as soon as possible. And once you know who's your weakest, coder in terms of coding accuracy or providers when it comes to coding accuracy, you can start educating them. Not just the weakest, but everybody. You should have ongoing training. For example, you can have a general type of education when you do on onboarding for a provider or Medicare adjustment 101. Now, after the onboarding, you can focusing on specific type of education, such as how to document diabetes, how to document cancer, things like that. The other thing is you need to have a clear and concise communication. When there is a change or coding guideline, a CMS regulation change, or internal policy changes, do you have a way to communicate that to your providers and your coders? Also, when there is a documentation ambiguities, nobody knows what to do. Do you have a process in place to come together to say, okay, here's what we're gonna do? You need to have someone who can make the final decision in that regard. The fourth thing is to prepare for the inevitable. And the best way to do that is to do your own internal RADV audit. Keep in mind when you do your own internal RADV audit, the goal is to identify logistical bottlenecks and areas for improvement. And your internal RADV audit should mirror as much as possible CMS processes, the way that CMS does it. For example, CMS will typically select a statistically valid sample. You need to do the same. Now, if your sample is too small, you will not be able to do any valid calculation to predict potential extrapolated amount. Also, your sample needs to be random. If you're doing an internal RADV audit for your organization, you cannot just select 50 medical records from providers that you already knew they are struggling with documentation, and 10 from providers that you already knew are doing a great job. That's not a random sample. Another thing that you could do is to simulate official notification. Send a letter to stakeholders in the organization. Let them know that there's going to be an internal RADV audit. So that way you can test your internal communication process. Other things that you may want to think about, you can even replicate the medical record retrieval process. For example, you can send some medical record requests to a sample of your providers and see who's going to respond, who's not going to respond. Test your escalation procedures for non-responsive providers. Now, when you do get these medical records, please keep in mind, your next step is not to start reviewing these medical records for HCC purposes, because this is not how CMS will do it. When you get these medical records, you need to review, you need to evaluate the quality and completeness of these records. The reason is that you want to test your best chart logic. Your best chart logic, why is that important? Because CMS only allows submission of up to 2 records per HCC under review. Now, let's just say you get 10 medical records to support diabetes. You need to know how you're gonna select the best 2 medical records you're gonna submit to CMS. That's why when you do your internal RADV audit, you need to do the same thing. CMS processes that when they do get these medical records, as we already mentioned, they will do a medical record intake. They are checking to see which record they're going to use for RADV audit. Only valid medical records that pass medical record intake are eligible for CMS HCC review. Now, what are some reasons for a medical record to be invalid? Wrong record, there's no name in the medical record. Missing signature. Name variation, patient's name is William Smith. Some visit you see William Smith, some other visit you see Bill Smith. So you can tell. Date missing, invalid medical record source, credential missing. Always keep in mind, do not assume the fact that these providers are on medical record, you're not going to have any of these issues. Don't assume that. That's why you need to do your own internal RADV audit. And when you do get these medical records, check for these items as well. Now, just like CMS processes, the one that passed the medical record intake review, now you can start reviewing for CMS to see which ones are validated. Now, CMS processes that each medical record may be subjected to up to 3 rounds of review by a certified coder. The question is that, do you have to review medical records by 3 different people? No, you don't have to, depending on how big is your organization. If you're a small medical practice, you're not gonna have enough different people to do 3 rounds of review. But the key thing to remember is that whoever was involved in the initial coding or submission should not be the one doing that RADV audit. It should be someone different. It could be another coder, it could be a coding manager. Now, CMS process is that they will get these records, they will code it, and then if it matches the HCC under review, good to go. Now, if there's a discrepancy, they're gonna do a second level review. If there is a variation between the first review and the second review, now they'll submit that to a third level review. Now, once you're done with your RADV audit, you see some issues, you need to have a root cause analysis. Now, when we say root cause analysis, you need to have a root cause analysis for each unsupported HCC. The reason is that you want to avoid generalized conclusions because not all unsupported HCCs are due to lack of documentation. It could be a data flow. That HCC should not have been submitted to CMS in the first place. Now, when you're doing your root cause analysis, please remember to bring every relevant stakeholders on board. Your coders to understand coding logic and potential misinterpretation. Your clinicians to provide insight into documentation practices and clinical reasoning. Provider relations to understand provider specific challenges. Now, once you have these people on board, please look beyond the surface. Don't stop at the obvious. If the documentation is lacking, keep asking why until you get to the root cause of why that documentation was lacking. And some possible root causes could be documentation gaps, coding errors, provider education deficiencies because the training was ineffective. It could be a system issue because the EMR was not conducive to proper documentation. Or it could be a process where it could be any different things. Now, once you have the root cause, you need to have a corrective action plan. And probably you may want to use the SMART goal. SMART, S for specific, M for measurable, A for achievable, and R for relevant, and T for time bound. Once you have your SMART goal, assign it to someone. Someone should take charge of it and give them specific time when it needs to be completed. And finally, it is very important to stay informed. The best way to stay informed is to register through the health plan management system called HPMS, which is the official communication portal for CMS and Medicare Advantage organization. You can register there. And also there's on CMS.gov website, you can look for, there's a dedicated section for RADV audit. Well, no one knows exactly how CMS is gonna do their RADV audit moving forward. But we can learn a lot from the past. Just doing some basic things such as coding using the official ICD-10 CM guidelines, coding clinics. Make sure that you have an internal RADV process in place. Update your policy and procedures. These things can go a long way and that can surely help your organization to be better prepared for RADV audit. Now I'm going to turn it over to Gary.
All right. Well, thank you, Dr. Gaton and Jean. This is a very thorough presentation. We've got a lot of comments here, people just expressing their gratitude for going over these topics. So thank you all. Now we got again a big audience today, a lot of questions that have come in. So if we don't get to yours, don't worry. Someone will reach out to you to make sure you answer your question. So go ahead and ask it. Even if we're running out of time towards the end. So let me go ahead and start here in no particular order. First question is this. Hi, Jean, can you please confirm on the MDD clinical validation for reporting again? Thank you so much.
Oh, so for this one, for the high-risk diagnosis, so CMS will check to see for antidepressant in their pharmacy data. If they don't see that in there, that may flag like suspicion, like maybe this major depressive disorder might be unsupported, and they will request for the medical record.
Okay, great. Hopefully that answers your question out there. If that didn't, go ahead and rephrase it, and someone will make sure that we get that to you.
I think as
go ahead,
a pediatric practitioner, let me just weigh in real quick, just to support what Jean said, but from a educational or training perspective, I think it's very important that we educate providers that it is incredibly important to link your ICD diagnosis with whatever treatment you're going to you're going to implement for the patient. That's where pharmacy claims come in, and other types of claims data. One of the things we've done is we are training physicians on what's known as diagnosis pointing, where again it links the ICD-10 to the CPT. I know in ECW it's in the billing window when you hit visit code or treatment code, and that again helps keep things in order and not become lost, particularly with complex patients where the note can be very long and winding. So again, if I diagnose condition A, I want to comment in the note about the status of that condition, and then what are we going to do for the patient relative to that condition? What's the treatment? Is it therapy? Is it a consultation? Is it a procedural code? Is it pharmaceutical treatment? And so again, it connects those dots because I think that's incredibly important. I as a CDI practitioner review a lot of audit results, a lot of audit findings. And unsupported codes are by far the most common finding in audits, at least for primary care physicians. Gene, I don't know if that's the right, but in my experience, in my world, it is the number one. It's unsupported codes, whether they are visit codes and treatment codes, whether they're vaccination codes. It's because things don't flow, and as providers, we're the storytellers. So we have to train our storytellers to be complete, to be accurate, to be specific, and to do it in an orderly fashion.
Great, thank you. Next question here is, do you have a recommendation of a standardized chart audit form coders should use to start doing audits?
I'll take that one. I think whatever works for your organization, you can customize your own, whatever the goal that you're trying to reach. Let's just say you can have audit or documentation requirements. For instance, you can say if you have diabetes, if you diagnose a patient with diabetes, here are some type of documentation information you want to include in there, such as the type. Is it stable? Is it uncontrolled? Things like that. Is there any complication? If yes, please make sure you link it. There's so many things that you can do. So it depends on your goal, whatever you're trying to achieve.
All right, next question here is, did I understand correctly that when and if you get audited, you will provide additional cases to the auditors for comparison to see if you coded the other cases in a similar manner?
Is it a RADV audit? For RADV audit, I don't think maybe you can do that during an appeal, but the first thing that you're going to do, you just submit that 2 medical records for that HCC using the new process, and then they review these 2 medical records. If one of them, supports that HCC under review, you're good to go.
Agreed.
All right. Next question is, what can you share regarding the quote, No Upcode Act that is pending in Congress? Anything to say about that?
Yeah, I don't have a comment. I've not had a chance to read through that.
Okay. More to come. Oh, yes, Gene.
So, currently, any coding compliance or any YG compliance, if they notice that an organization is doing, up coding, you can go, get into trouble. So I don't think if a new law gonna make a difference, but currently any upcoding, depending how big it is or depending what the government decides, you can get into trouble for upcoding.
Well, I'll try to convince Gene and Dr. Gouton to write a little article for you to compound a little bit more on that. So so stay tuned. Last question that we have time for today is this one. Are these increased audits targeted only at Medicare Advantage or health plans, or would a health system, hospital clinics, medical groups also be at risk for direct audits as well for programs like MIPS, promoting interoperability, etc. And a comment about it before you answer, it says the CMS announcement seems to focus on MA health plans, so it's a little unclear if hospital systems are directly impacted. Thank you.
Well, the announcement certainly is directed at MAOs, but I think that, as I said earlier, it's a signal that audits are going to occur with greater frequency because there's a need for greater scrutiny about how the medical dollar is being spent. So it really doesn't matter in my mind what your organization is. If you're taking care of patients, if you are receiving payment from the federal government, you're likely to see more audits. And these practical recommendations and sort of audit preparedness advice is something that I would, I would apply in my company. Gene?
Just keep in mind that the health plan may request some documents, some medical records from your organization, from your medical practice, or from anybody. If you're a specialist, they may request medical records from you. And sometimes now the health plan may have in the agreements they have with the practice, if there's something happen, there's an audit, something wrong happen, they may wanna bring it to your attention. You may have to pay something as well because you're responsible for your own documentation. That's something that all practices should keep in mind.
Clinical documentation is important for prior auth, for medical necessity. So I think it's something that you need to look at within and across your provider networks to make sure that the clinical information in the progress notes supports whatever codes are being submitted.
Great. Well, unfortunately, that is all the time we have, and we do have some more questions. But again, don't worry. If you ask one of those questions, someone will reach out to make sure that we get those answered. I know there's a lot of a lot of buzz swirling around all this stuff. So glad you joined us today. And I wanted to give a special thank you to Dr. Gutton and to Gene for just a fantastic presentation. As we close out, I would encourage you all to head over to vbcexhibithall.com and check out the Symbion virtual exhibit booth. And you'll be able to read up on them a little bit more and dive in and kind of do a deeper dive on where they are and, of course, get in touch with them. And I guarantee you will be in good hands if you do need some assistance in this area. And I'm happy also to facilitate an introduction if that's easier. But check it out. Also at VBC Exhibit Hall in the library is where you're going to find the archive that will have all the webinars we've ever done, including the webinars that we've done with Symbion. And there's a lot of great material there for reference. And of course, if we can be of any help or point you in any direction, happy to do so. And then finally, if you would like to reach out directly to Gene, to the Symbion team, to Dr. Gutton, please do so here, where their information is here. You can at the info ad, and that'll go to the right place. Or again, feel free to reach out to me. I'm happy to facilitate an introduction. But thank you all so much for joining us. Appreciate you spending part of this beautiful summer day, hot summer day for most of the nation with us today, and hope you join us on the next one. So until then, have a great rest of your week.
Thanks, everybody.